Hello and welcome to Yodo. I'm Dr. Bohm. This channel is a place where information regarding serious illness can be obtained in a less frightening environment. Thank you for forwarding this information to your family members so that if they need insight, they can also be provided that opportunity to learn. Your comments and questions are truly helpful to develop the content. This will be a discussion to provide additional insight and examples of another of the many symptoms that can be difficult to manage for some patients and families when a loved one has dementia. Today we're going to cover information about sleep issues in dementia patients. We do have another video on sleep issues, but this information today specifically relates to addressing the needs of a person with cognitive impairment. We've established that among the multiple different types of dementia, many are hallmarked by specific issues, symptoms, trajectory path, and behaviors. Knowing the cause, the dementia type, can be helpful at earlier stages, especially with possible treatment interventions. It can also be helpful for predicting that trajectory and the progression, as well as helpful anticipating what decline will look like and when some of those symptoms may be noticed. But the type of dementia is not so important in the later stages, particularly with certain behaviors that would need to be managed. Sadly, for nearly every cause of dementia, there is no cure if the damage has been done and those cells have died. The cell and the information that it contained is likely gone forever. New medications are being evaluated all the time. Plus, the brain is amazing, and the other cells in the area of that cell can learn to do certain tasks, but they're not likely to relearn all that information that cell contained, and so that information may be lost forever. Sleep issues are a common problem for patients with cognitive impairment. Overall, it's common for anyone with cognitive impairment to develop sleep issues, and those progress over time. Some types of dementia, it's more common for the internal clock to malfunction and that person to become more sleepy at the wrong time of day. They can stay in bed too late, they can have shorter periods of wakefulness, and feel like they've got longer periods that are occurring with non-restful or non-fitful sleep. They can be disgruntled at different times of the day, and that may be due to the fatigue. This all further disrupts that circadian rhythm, and the downhill spiral can progress. Night disorientation is common, and it happens because of multiple contributors. Hearing may be impaired, vision is likely not optimal, and if lighting casts shadows, it could be frightening. Some types of dementia are more likely to have associated symptoms of hallucinations and delusions, particularly Parkinson's, Lewy body, frontotemporal lobe, but it can occur with nearly any type of dementia. If these are not frightening, it might be just best to kind of go along with the flow and agree with the patient, just don't encourage them. If they're frightening delusions or hallucinations, they really do need to be addressed. Basics of dementia, regardless of the type, include a disease process that is a thief, and it takes away parts of the person that allows them to be who they are and remember facts. Facts about themselves, facts about dates, locations, activities, and prior experiences. Facts about family members, but generally strength is not a part of what's lost. It takes away some communication skills, the ability to consistently and accurately interpret their surroundings. They can lose the ability to consistently and accurately process data from themselves and their environment. And there can be loss of ability to consistently and accurately make their needs, wants, and thoughts known. It can even interfere with their ability to interpret what their own body is telling them. And that's pretty scary. Not just to hear, but to experience. If you keep that in mind, the patient may be afraid. It will truly assist you with your interactions with them. Use these tips to help guide your interactions with patients with cognitive impairment. Agree, don't argue. Divert, don't reason. Distract, don't shame. Reassure, not lecture. Reminisce, and avoid the word remember. Reassure what they can do, and avoid the phrase you can't. Ask, don't demand. Encourage, don't condescend. Don't force. Instead, use methods to gain the patient in agreement to try. When we communicate with a patient that has dementia, it is recommended to not get in their face. The person doesn't have complete loss of their ability to interpret, but they just don't interpret things as fast and as completely well as they did before. So if you get right down in their face, you may shock them, and you could activate their amygdala, and then that fight or flight response is going to be triggered. So space and your approach are important when dealing with these patients. You might have some written reminders in particular locations around the house, such as the bathroom or the kitchen, because sometimes this can help remind them, because sometimes frequent questions are going to be asked. Sleep issues are the norm for patients with neurologic issues because it is your brain after all, and the brain does need to rest. Patients with cognitive impairment typically have issues with day-night orientation, and becoming disoriented is really common. It is more involved than maintaining a good routine and supporting a natural circadian rhythm. But also important are room lighting, noise levels should be appropriate, and there's a video on this channel about sleep and insomnia with some helpful ideas. Yet patients with cognitive impairment can be expected to have progressive issues with their sleep. Without managing these little but very important things, the sleep issues are going to be worse, and bad sleep habits can become very difficult to manage very quickly. As cognitive function progressively becomes more impaired over time, more support will be needed, and more issues are likely to occur. Just like nearly everything else, change is the only constant. Being proactive is going to give you a terrific head start, and some of these issues may be much easier managed if they're captured early. In the sleep video, we established that the importance of routines will really help support good quality sleep. And we also discussed typical sleep-wake cycles by age, young kids, adults, and then the sleep patterns that are typical for people over their mid-60s. But we really didn't talk about the patterns of the extremes of age. Infants and people with neurologic conditions, not solely limited to dementia, can have similar sleep patterns and similar sleep needs. As any parent will tell you, sometimes even with the best efforts and routine that you could possibly provide, some nights are just pretty rough. And that's true for patients with cognitive impairment as well. We know that infants don't sleep well, typically waking during the night several times. They haven't learned yet how to comfort themselves, and so they may need someone else to help them soothe themselves to go back to sleep. Similar sleep disruptions can occur with patients with dementia as well. Many chemical changes are occurring in the brain in people with dementia, one of which is the change of the melatonin level. These levels may need support, and many patients can benefit from the over-the-counter supplement of melatonin. For some patients, vivid and uncomfortable dream sequences may be occurring, and sometimes melatonin can actually aggravate this. You will know in 10 to 15 days if melatonin is going to help or not. And just because it didn't work 6 months ago doesn't mean that it won't work now. Sometimes you may have to go back to the beginning and start over. Melatonin is a sleep initiator only. And so if getting to sleep is not the issue, it's early morning awakening or inability to maintain sleep throughout the night, a different intervention or likely medication may be needed. In the sleep video, we talked about CBT, cognitive behavioral therapy, and that's not likely to provide any assistance for a patient with cognitive impairment. I have encountered families over the years that have reassured me that the patient worked nights or swing shift, and that was their normal sleep pattern. All is well and the family is used to it. And that could be the case, but it might not. There can be subtle ongoing changes in the sleep-wake pattern that may indicate that the sleep cycle is spiraling out of control. Loss of a regular pattern can be one of the more common reasons a patient is otherwise easy to be cared for now requires additional assistance. To be clear, I'm not talking about somebody with mild cognitive impairment or maybe even early stages of moderate dementia. But patients with moderate or severe dementia can certainly have the ability to perform some of their activities of daily living. Yet if the patient is up wandering about the house in the middle of the night or possibly trying to leave the house in the middle of the night, that may trigger awareness that living in the family home is no longer suitable and safe environment for the patient. Thus, the importance of a good sleep routine can take on an entirely new priority. Therefore, we want to reinforce those good sleep habits. Patients with dementia feel that there's something changing, and the routine is very reassuring. Having a regular evening ritual goes a lot further than you might guess to helping the patient feel reassured that everything is okay and it's on a steady course. A light snack, of course you want to be careful with food and fluid and the timing of that, but a snack at bedtime may be beneficial. Maybe some light music, brushing teeth, dimming of the lights, toileting for sure, taking a bath or washing up, and putting on some lotion and then their pajamas can help them realize that sleep time is near. Other considerations may include a comfortable bed and pillows, appropriate management of medications. You don't want to give a diuretic or a stimulant at bedtime, Caffeine and nicotine can interfere with the sleep-wake cycle, so those aren't good to use at bedtime. And for sure, keep up with other health issues that might interfere with good sleep. So if they're having trouble with shortness of breath, or if there's a sleep apnea machine that needs to be used, restless leg symptoms need to be managed, and certainly pain needs to be managed at bedtime and during the night. Having a good morning routine also helps. Getting up at the same time 7 days a week. And I remember when my kids were little and they would come in on a Saturday or Sunday when I could sleep in a few hours, and they would tell me happily that the sun is up. Younger children and older adults don't realize the difference between a weekday and a weekend. And so it's important for them to have their routines established and keep to those routines day in and day out, regardless of the day of the week or a holiday. The patient with dementia needs to get up and stay with that routine. Participate in their golden hour events, and we do have a video regarding golden hour events, and that's important for a patient to maintain those activities because it's going to help them stay in their own home. All of us benefit to see the sun each day, so get the shades up or at least turn on the lights. Maybe have some coffee or tea and breakfast. Patients with cognitive impairment want to be active, and maybe there's time for a walk, and if they can work on a hobby or have a project, that will help occupy their minds and their hands. People like to accomplish things during their day, and people with dementia also appreciate being able to accomplish and finish a task. We as humans have needs and likes and preferences. We like to have things to do that keep us busy, but not too busy. We like to be successful. Having met a challenge successfully helps us build resilience. We build resilience when we succeed at meeting a challenge. Having daily challenges that we can meet make us feel accomplished and successful and can bring us joy. Being hit with challenges that are out of our control and that we can't meet can result in a sense of failure, and it can cause a lot of issues with a person's mood. It can result in depression, sadness, and sometimes even despair or PTSD, depending on the severity and the frequency of those insults. And we certainly don't want that for ourselves as well as our loved one. We want enjoyable tasks at which we can succeed, things that bring us joy to our day, and it's going to give us a better day for everyone that's involved. And that's what we want. At the end, when the time is winding down to our day and the process begins for getting ready for the end of the day, we want to be able to reminisce about the successes that we've enjoyed during the day. Things that maybe we weren't successful at today, we should omit that when you're reminiscing with your loved one about the day's events. Those details leave out of the storytelling. Storytelling is a very important part of the human fulfillment component. And so I please want you to participate in that fulfillment with your family members and help them reminisce about their successes each day. For many, recalling those day's successes will help with that bedtime routine. Daytime naps can sometimes be helpful. Maybe between 2 and 4 o'clock in the afternoon might be a good idea, but if they do participate in naps, keep them short. Just as with young kids, being a little bit weary in the afternoon can make them grumpy and further their issues with interactions. There are some patients that without a light afternoon snack or a short nap, they can become quite distraught at about sundown. If the pattern of sundowning escalates and continues, it may also prompt consideration that the patient is no longer able to stay in their own home. So let's have a little sidebar on sundowning. Sundowning refers to the phenomenon that can occur in patients with dementia and cognitive impairment at about dusk. So earlier in the winter and later in the summer. Sometimes pacing or wandering may occur. This can occur at any stage of dementia and again with any form of dementia. It's more common in the later stages though. Mental and physical exhaustion are considered to be contributors to sundowning when it occurs. I've often wondered if the patient runs out of their neurotransmitters in that part of the day, such as with a child maybe being tired and they're already feeling that sleep pressure build, and so they're beginning to try to fight sleep. At this time of day, many patients with cognitive impairment can become acutely confused. They can have a significant amount of anxiety, agitation, and can become angry and very disoriented. They can become acutely moody, suspicious, and sometimes very difficult to reorient to time, location, and purpose. They might have delusions or hallucinations. And with attempt at diversion or reorientation, sometimes they can become very distrustful or even angry. Reorientation from an episode of sundowning really needs to be done delicately, as you can further their agitation if you become too assertive. So refer back to those tips I gave at the beginning of this talk. Often the person can become so agitated that attempts at distraction will not be successful, and efforts for reorientation could even make them more upset. Going through mental gymnastics of possible triggers is a good first step. Consider fatigue. Have they been too active or maybe too inactive today? Could they have been hungry or thirsty? Are there toileting needs that need to be met? What about a change in their routine? Have medications been delivered on time? Did something get missed or delivered early or delivered late? Could it be a hormone level that's changing? Is it an issue with some clothing? Could they be sad or lonely? The brain no longer has the higher ability of function that it once did, and so too much information can cause something that we all feel at times. Sensory overload can occur. Again, resist the urge to get in their face, to argue, or to discount what they feel. Listen to their comments and try to restate their concerns to indicate that you hear them and that you understand, and try to reassure that person that you're going to take them seriously and you're going to make every effort to address that concern. You might even thank them for pointing it out. Is it something that you could agree with? Sometimes you can find a trigger, the event. You can find out what the comment was that set them off, or maybe it was a TV show. After going through all those things that they might need or that you could possibly fix, whether it's a snack or drink or going to the restroom, but if it is a severe problem and it occurs regularly, medication may be needed. Your doctor and your medical team are going to help you determine what is needed and the timing of that medication. Sometimes the physician may recommend starting at a low dose and escalating it over time, and other times the symptoms are so severe they may be more aggressive with starting that medication and then reduce the dose as improvement is noted. I once had a patient that I cared for, and the patient's caregiver was her spouse. And he brought her in and he told me that every afternoon at about the same time she would become very upset, and they would have discussions about where their house was and that she wanted to go home. And no amount of reassuring her that that was their home could convince her otherwise. And he stated that they had moved into that house when their children, who are now in their 50s and 60s, were born. So he said, we've lived here many, many years, and things in our home really haven't changed that much. So one afternoon, at her insistence, he got her in the car and took her for a drive around town. They went to the local Sonic and got a soda pop. And then she finally seemed to settle down and was ready to go back home. And he drove them past the house that they lived in when they were first married. And he said she didn't recognize it. So he kept on driving for a little while, and he took her back to the house that they had just left. And she said, oh, here we are. We're at home. And he said it occurred to him that she recognized their house from the outside. So every afternoon when she would become upset or a little bit distraught, he would take her for a car ride around the block. And when they would approach the house from the outside, she would recognize it and she would be calm for the rest of the evening. Back to sleep, or so to speak. But just what is happening when the patient doesn't sleep well? Because of the changes in the brain and the resulting decline in the cognition, there's a decreased ability to process the information correctly. There's a resulting impairment of the sleep pathways. We are unable to get to the correct stage of sleep, and we do not remain in the correct phase of sleep for the right amount of time. As the neurologic damage progresses, the sleep disruption often advances with it to a certain point. Then it seems like the patient does begin to again rest and begins to sleep more. But studies don't indicate that that is fitful sleep, that the patient has reached the same amount of fitful sleep that they had earlier in life. Patients with end-stage dementia, and by saying end-stage, I mean that at this point they have reached significant amount of disease burden. And at end stage, patients will no longer have the ability to walk without assistance. Sometimes they may have the ability to stand and pivot, but they may need two people to assist them to do so. At that point in the disease, they may need as much as 16 or more hours of sleep in a 24-hour time period. Typically not in one sleep session, but certainly 3 to 6 hour long sessions 4 or 5 times a day. Their wakefulness may be as short as just an hour or two. Sometimes they may be awake as long as 12 hours in a row, but it varies person to person, and sometimes that can vary day to day. Unfortunately for some, there may not be any remaining reliable pattern to their sleep. All of this results in significant stress on the caregivers. Thus the advice to intervene early and often if sleep patterns are changing. It might seem like this is harmless to let the person stay up till all hours of the night for a few days, but if it turns into weeks and then results in ongoing of months of altered sleep, it may not be working for you anymore. So you need to soothe your own tired eyes and tell yourself it's because that they've always been a night owl that this is happening. That may not just be enough. We can be affected by lifelong sleep pattern alteration. So people who were night shift workers or swing shift or had disruptive sleep patterns before, that may not be correctable, as there is considerable difficulty changing those lifelong sleep habits. That doesn't mean give up. Just keep working on it. Just keep trying. Being kind to yourself is important as being kind to the patient. Having them keep to a bedtime is not being mean. You do need to be kind how you do that and how those interactions go. You want to use those tips that we gave back at the beginning of the video again. Additionally, patients with dementia likely have other medical issues, and they're on medications that can adversely affect sleep. So we just don't have the technology or the medications at this point in time to replenish sleep that substitutes for natural sleep. Medications can help sleep, and they may be necessary, but the quality of sleep may be sacrificed. Tough choices and medication trials might lie ahead for some of these people and their families. There are numerous sleep medications available, and we're not going to go through those here and now, but to say that some will initiate sleep, like melatonin, and others will maintain sleep. Any of these medications, though, can have side effects. Just to name a few, dizziness and fall risk, and that's why Benadryl is not recommended for the geriatric population and certainly not recommended for patients with cognitive impairment. Worsening forgetfulness, and that's the reason we try to avoid tranquilizers. But sometimes these are necessary. Change of appetite. Some antidepressants can result in weight changes. Weight loss and appetite changes can be common and digestive issues that are typical for patients with dementia, but weight gain can also occur. And weight gain is not a good thing either because it can contribute to their balance issues and their fall risk can increase. Poor sleep can affect the mood the whole next day. Mood and energy can both be affected. Sundowning is a change of mood that's a sudden one, but there can be other mood changes that are not so sudden. So let's talk just a few minutes about mood issues. Mood can encompass a huge topic for dementia, and we're not going to jump down that rabbit hole today either. That being said, regardless of the cause or the dementia type, we know that the disease process advances slowly and continually. Various abilities and skills are lost. And as those abilities and memories are reduced and lost, the strength will remain the same, but their energy and endurance may not remain the same, and they're likely to become fatigued more easily. Thus, there is a great importance on the need of non-threatening and non-challenging environment. We need to reassure the patient and keep them feeling safe. We also want them to be content, preferably happy. Anyone, likely most everyone, has had mood changes from time to time, and sometimes we're not exactly sure what triggered that mood change. But for patients with cognitive impairment, they're going to struggle to recognize that they've even had that mood change. They may not process it well. They may not realize that it's occurred. They may not understand and see that a switch has been flipped and they're having an acute mood change. Keeping an active eye on your patient and being sensitive to their concerns, their worries, their fears, and their triggers is important. If the patient becomes withdrawn or seems to have an upset look on their face, try to give them some time and attention to determine what is happening. They may perceive a change that is not accurate, and if it's addressed quickly, the situation can be diffused pretty quickly. Try to determine what their perception is and what needs to be adjusted so that they're less upset. As cognitive decline progresses and the disease advances, there is not loss of ability to feel emotions. Sometimes those emotions may become stronger. The change may be that the person does not retain the ability to manage all those emotions that they feel. It could be a TV show that triggers a memory, or the person becomes very involved in a show, and then when it comes to an end, they've not processed the information as quickly as the show came to an end. I myself, I'm not a big fan of either sudden endings or cliffhangers. I just don't feel like there's good closure in the TV show. But it could have been an event with a family member. Maybe it was the way supper came to an end. So you have to look at what those situations are that are causing those mood changes. If you've noticed that a particular show or movie has been one that upsets the person in the past, it might do so again, and it's a good practice to avoid it. And if there's a show or movie that seems to calm or soothe them, or a particular kind of music that they like, it could be that it's one that you're trying to watch in the afternoon on a regular basis to try to help them through some of those more difficult times of the day. You may be tired of 101 Dalmatians, but they may find it really comforting and they may really want to watch it again every afternoon. Support with words and comforting touch your loved one as often as you're able to. As we age, we need to have that reassurance often. Non-sexual touch is very important for people with cognitive impairment to help them maintain happy and stable moods. Many realize that what they are needing is more assistance, and some are very aware of their diagnosis and what lies ahead, and they fear being a burden or fear being left alone and being abandoned. Reassurance, feeling safe, and feeling loved is very important. How to reassure them can be unique person to person. No one knows your family member better than you do. Typically, what has worked in the past will work again. Occasionally, though, a patient may have had a dramatic change and an entirely different approach may be needed. Humans are mammals, and we are more like other herd or pack animals. We like to be around others. There are benefits to being around others, and feeling safe is one of them. Threats don't seem as real when the lights are on and there are others around, but too many lights are going to interfere with their ability to sleep. Too few of lights may cause a trip hazard or may cast shadows. So you have to learn what your loved one actually needs and what they do best with. Keeping your patient reassured can provide significant encouragement and aid to decrease those mood issues. If the mood is low or they are feeling sad, they may respond to simple interventions of compassionate and reassuring words, but there are many other possibilities and ways to help. The person may need to address concerns regarding spiritual issues, particularly early in the diagnosis phase. When a patient receives a diagnosis of cognitive impairment, it can be devastating. If you have advantage of a palliative care team or a hospice team, a trained spiritual expert is included in that team. I've interviewed Chaplain Ski on the channel before, and you can watch his videos if you've not seen them already. I can probably sway him or one of his colleagues to return if you guys would like. Other mood changes may be present due to a patient concern or a family member concern as they look to the future. Palliative hospice teams also have social workers, and they assist patients and families navigating more than just the mood issues, but they can dig into some of the material concerns that might be behind some of the changes. Sleep and mood are intertwined with cognitive impairment. And like a catch-22, if sleep is poor, mood can be affected, and the result is going to be worsening cognition. The goal is to live the best life we can every day, having made the most of each and every event and every interaction with others. Our time may be limited on this earth, but the amount of joy and fun, the amount of love and happiness should not be limited. When a diagnosis of serious illness has been made, we need to bond together even tighter as humans to support one another. End of life is a journey that we are all moving toward. For some, death will be seen approaching long before it arrives, and we can make that remaining time count and squeeze every ounce of good and joy out of what we're given. In summary, this covered additional information and insight into caring for patients with dementia, specifically regarding those sleep concerns. We reviewed a few basics. Each dementia type and every person is a little bit different in their symptoms and presentation and trajectory and prognosis. Yet patients with dementing illness, regardless of the type, have some similarities as the progression advances. Many factors contribute to each patient's needs and issues. Your approach is important. Don't come up to the patient quickly and don't get in their face. Avoid topics that might be upsetting. If they're momentarily forgetful of a death or a frightening event, it might serve them better to just go along with it and use plausible deniability. Don't contradict them because the escalating event that follows could occur pretty rapidly. All change is stressful. Change in a routine might be brought by an illness, might be occurring from progression of the disease. It might mean more changes in meds are needed, and it might mean that a move is needed. If a move is necessary, decline will certainly occur. Good morning routine, a day with interesting activities to keep the mind working and happy, and a body that is busy are all good interventions. Success with little challenges can bring a sense of accomplishment and happiness. Possibly offering short periods of rest or maybe a snack in the afternoon followed by a light supper before bed And then keeping that bedtime ritual are also good ways to help a patient with dementia have good quality sleep and result in their ability to stay in their own home. Sleep can affect mood and cognition, and when it's compromised, it will likely further impede the ability of the person to interpret their surroundings and make their needs known. So good sleep and a regular routine can aid and keep that sadness and depression at bay, because that sadness and depression affects not only the patient, but the family as well. Follow up regularly with your medical team and keep on top of those trends and changes that are occurring. If you haven't already, watch the other content on the channel related to dementia and leave a comment. I'm Dr. Sarah Bone, and I want to thank you for your time. Bye now.